Hey everyone, thanks for tuning in. I know you're all super busy, so I really appreciate you taking the time to join us for another deep dive.
Absolutely. We're excited to have you here.
So today we're tackling a tricky topic.
A tricky case, really.
Yeah, a tricky case of pyelonephritis.
And we're going to be walking you through it step by step, just like you might see in a clinical setting.
Exactly. So let's meet our patient, shall we?
Yeah, let's.
We've got Sarah, a 38-year-old high school teacher who also happens to be managing type 1 diabetes.
Okay. Already that's a bit of a red flag.
Right. Diabetes can make infections a bit more complex.
Absolutely.
And she comes into the ER with, well, a whole bunch of complaints.
Like,
She's got right flank pain that's been bugging her for the past 24 hours.
okay, flank pain, that's
Yeah, that's not good.
definitely a sign something's up.
And it's not just that. She's also got some abdominal pain, nausea, chills, and fever.
Oh, the classic quartet.
And here's the kicker. She's actually already 2 days into treatment for what her doctor thought was a simple UTI.
Oh, so she's been on antibiotics.
Yeah, trimethoprim
A little
sulfamethoxazole.
bit TMP, SMX, the dynamic duo.
But clearly it's not working.
That's concerning.
Yeah. So time to put on our detective hats, right?
Let's gather some clues.
What can you tell us about Sarah's presentation so far?
Well, subjectively, she's telling us about chills, pain in her flank and abdomen, feeling nauseous,
Yeah.
and the fever, of course.
And she's had UTIs before.
Yeah, she mentioned a history of UTIs, which is important to note.
Okay, so what about the objective findings?
Her temperature is elevated at 39 degrees Celsius. That's pretty high.
And she's showing signs of dehydration too.
Yeah, her skin and pharynx are dry, so we need to keep that in mind.
What about the physical exam? Anything noteworthy there?
When we examine her abdomen, there's tenderness in the suprapubic area.
But no rebound tenderness regarding.
Thankfully, no.
Okay, that's good.
That's good.
So let's move on to those lab results. What are they telling us?
Her white blood cell count is significantly elevated. It's at 22.3 by 103 per millimeter 3.
Wow, that's high.
And there's a left shift, too, meaning there's a higher proportion of immature white blood cells.
That's a hallmark of bacterial infection.
And it is.
Her urinalysis is also,
Also pointing towards an infection.
it's cloudy, bloody.
And positive for leukocyte esterase and nitrites, all classic signs.
What about imaging? Did they do any imaging?
Yes, she had both an abdominal ultrasound and a CT scan.
So what did those show?
The CT scan showed some contrast buildup in her right kidney, indicating inflammation and impaired clearance.
Okay, so not just a simple bladder infection then.
No, the ultrasound also showed changes in the right kidney consistent with pyelonephritis.
So we've got a whole bunch of clues pointing toward pyelonephritis, but before we jump into treatment,
Pop quiz time.
pop quiz time. What are the key findings in this case that really scream pyelonephritis?
Give everyone a second to think.
Take a moment, listeners.
All right, time's up.
The answer is
Well, go ahead. The combination of flank pain, fever, chills, and those really abnormal lab results, especially that elevated white blood cell count with a left shift, and of course the findings on those kidney images.
exactly. It all paints a pretty clear picture.
Definitely something more serious than just a bladder infection.
So how do we determine how severe Sarah's condition actually is?
We have to consider everything, all the information we've gathered.
A whole picture.
In Sarah's case, that high fever, the significant pain she's in, and the abnormal blood work all point to the need for hospitalization and IV antibiotics, like right away.
Okay, so no messing around here.
No, pyelonephritis can be serious. We don't want to risk it spreading.
What could happen if we just sent her home with some oral antibiotics and hoped for the best?
Well, the infection could spread to the bloodstream, leading to sepsis, which is life-threatening.
That's definitely not what we want.
And there's also the risk of permanent damage to the kidney itself.
So we need to act fast.
Time is of the essence.
We also can't forget about Sarah's other health challenges.
Right, her diabetes.
What else do we need to consider?
We have to monitor her blood sugar very closely and adjust her insulin if needed. And we also need to address that potential dehydration.
That dry skin and pharynx.
Yeah, it could be contributing to her condition.
Okay, so we've collected all this information. We've assessed the situation. What's next?
Now it's time to develop a plan, a care plan for Sarah.
What are our goals here? What are we aiming for?
Our top priority is to completely eliminate the bacteria that's causing this infection.
No survivors.
We want to make sure it doesn't come back and cause problems later on.
We also want to get her feeling better, right?
Absolutely. We need to bring down that fever, manage the pain, ease the nausea.
And of course, manage her diabetes and get her rehydrated.
All of that is crucial for her recovery.
So medications are going to be important, but what about other things we can do? Non-drug therapies.
Fluids, fluids, fluids. Encourage Sarah to drink plenty of water.
So simple, yet so important.
It helps with dehydration and helps flush out bacteria from her urinary tract.
Two birds with one stone. We'll start with IV fluids and then transition to oral fluids, I assume.
Exactly. And now let's talk about the big guns, antibiotics.
Oh yes, the heavy hitters. Ready for another pop quiz?
Hit me with it.
True or false? Nitrofurantoin is a good choice for treating pyelonephritis.
Ooh, tricky one.
Give everyone a moment to ponder.
All right, time's up. The answer is false.
Ding, ding, ding. You got it.
Nitrofurantoin is great for uncomplicated UTIs, but it doesn't reach high enough levels in the kidneys to really be effective against pyelonephritis.
So it works for the bladder, but not the kidneys.
Exactly.
In Sarah's case, we need something that can get into those kidneys and target the bacteria that usually cause these types of infections, which are...
Gram-negative bacteria, primarily E. coli.
So what are our options here? What are our go-to choices for tackling pyelonephritis, especially when someone needs to be hospitalized?
Well, fluoroquinolones are often a good starting point.
Like,
Ciprofloxacin and levofloxacin are good examples.
and they come in both oral and IV formulations.
That's right, which gives us some flexibility.
So we could start her on IV ciprofloxacin in the hospital, and then switch her to oral levofloxacin when she's ready to go home.
That's a common approach, but the dosage and duration will depend on her specific needs.
Personalized medicine, gotta love it. What about those extended spectrum cephalosporins? When would we choose those over a fluoroquinolone?
They're a good option if we suspect the bacteria might be more resistant, especially if the patient has had a lot of antibiotic exposure in the past.
So if someone's been on a lot of antibiotics before, these might be a better choice.
Yeah, ceftriaxone and cefepime are two common examples.
Any other options we have up our sleeve?
We could consider aminoglycosides, like gentamicin.
But aren't those a bit rough on the kidneys?
They can be. They have the potential to be nephrotoxic, which means they can damage the kidneys.
So we have to be careful with those.
We use them cautiously and monitor kidney function closely.
So it's a balancing act, making sure we're treating the infection without causing more harm.
Exactly. Risk versus benefit.
You mentioned earlier that TMP-SMX isn't a good choice for pyelonephritis, even though Sarah was already taking it.
Right. There are a couple of reasons for that.
Can you elaborate?
Firstly, she's already taking it, and it's not working, so the bacteria might be resistant to it.
Makes sense.
Plus, even if the bacteria were susceptible, TMP-SMX doesn't always reach high enough concentrations in the kidneys to reliably treat pyelonephritis, especially a severe case.
Okay, so we need something with a bit more oomph in this situation.
Exactly.
So we've talked about antibiotics, we've talked about fluids. What about actually putting this care plan into action?
Monitoring is crucial. We have to keep a very close eye on Sarah.
Like what specifically? What are we looking for?
Her vital signs, her temperature, blood pressure, heart rate, all of that.
And her labs.
Yes, her white blood cell count. And if we're using an aminoglycoside, we need to watch her kidney function closely.
Got to keep those kidneys happy.
Absolutely. And we need those urine and blood cultures to see how she's responding to the antibiotics.
Do we always stick with the initial antibiotic choice, or do we ever adjust based on those culture results?
We absolutely adjust. If the cultures show something different than we expected, or if the bacteria are resistant to the antibiotic we chose, we switch gears.
So we adapt based on the information we get.
Exactly.
Speaking of information, what about patient education? What do we need to tell Sarah?
Patient education is so important. We want to make sure she understands everything.
Like how to take her medications correctly.
Absolutely. The right dose, the right time, and for the full duration.
No stopping early just because she feels better.
Right. That's so important.
We also need to talk about potential side effects.
Right. What to expect and what to do if she experiences anything concerning.
Especially with those fluoroquinolones, those can have some
unique side effects, yes.
Okay, so we've covered a lot about implementing the care plan, but what about after she goes home? Follow-up is key. What does that entail?
We need to make sure she gets those microbiology reports. See how she's responding clinically. Is she feeling better?
And her labs.
Yeah. Depending on which antibiotics we choose, we might need to do some more lab monitoring.
And what about switching from IV to oral antibiotics? How do we decide when it's safe to make that switch?
That's a great question. There are a few things to consider.
Like what?
First, is she clinically stable? Her vital signs should be normal, no fever, and she should be tolerating oral fluids well.
If she can't keep the pills down, there's no point in switching.
Exactly. We also need to think about the specific antibiotic. Some are absorbed better orally than others.
Right, and we need to make sure the bacteria are still susceptible to whichever oral antibiotic we choose.
It's a team effort, everyone working together.
Doctors, pharmacists, nurses, and of course Sarah herself.
Couldn't agree more.
So let's fast forward a bit. It's day 3 of Sarah's hospital stay. She's feeling much better, her fever is gone, and we finally have those culture results.
The moment of truth.
What do they say?
Both the urine and blood cultures grew E. coli, which isn't surprising.
The usual suspect.
But the susceptibility report is interesting. It shows resistance to ampicillin and, as we suspected, TMP-SMX.
Not a surprise there.
But thankfully, it is sensitive to ceftriaxone, levofloxacin, and ciprofloxacin.
Okay, pop quiz time. What would you recommend now? Should we change Sarah's treatment plan? Think about it, listeners.
This is where it gets really interesting.
It's all about applying what we've learned.
Absolutely. Welcome back to Bugs and Beyond. Ready for round 2.
Absolutely. Last time we really dug deep into that complicated pyelonephritis case, figuring out how to recognize it, how to pick the right antibiotics, and even how to change the plan based on those culture results.
Right, we got into the nitty-gritty.
But we didn't just want to stop at the what.
We want to understand the why.
Exactly. Because as healthcare professionals,
we can't just memorize a list of drugs, right?
Right. We need to understand how they work, their mechanisms of action, so we can make the best decisions for our patients.
Informed decisions, that's what we're after.
I'm all about connecting the dots, so let's jump in. Mechanisms of action, it's been a while since pharmacology class.
It's always good to have a refresher.
Especially when we're talking about treatments that can really make a difference.
Absolutely. So let's start with the fluoroquinolones, our good friends levofloxacin and ciprofloxacins.
Okay, those were some of our top contenders for Sarah's case.
Right, and they're bactericidal.
Meaning they actually killed the bacteria.
Not just stop them from growing, they kill them dead.
How did they do that?
They inhibit 2 key enzymes, DNA gyrase and topoisomerase IV.
Okay, I vaguely remember those from school, but remind me, what do those enzymes actually do?
They're essential for bacterial DNA replication and repair.
So without them,
the bacteria can't make copies of themselves.
And their DNA falls apart.
Essentially, yeah, it becomes unstable and they can't function.
So the fluoroquinolones basically sabotage the bacteria's ability to reproduce and survive.
Exactly. They mess with their blueprints.
So smart. What about those extended spectrum cephalosporins? How do those work?
They're also bactericidal, but they target a different process. They interfere with bacterial cell wall synthesis.
The cell wall, that's like the bacteria's armor, right?
It's their protection, their shield.
So if you mess with its construction,
they become vulnerable.
Makes sense. How do they do that?
They bind to penicillin-binding proteins. These are enzymes that are involved in building the cell wall.
So the bacteria can't build their armor.
Exactly. They're left exposed.
It's like taking away their shields in the middle of a battle.
Perfect analogy.
What about those aminoglycosides, like gentamicin? How do they fight the bacteria?
Aminoglycosides are a bit different. They interfere with protein synthesis.
Okay, so they mess with the bacteria's ability to make proteins.
Right. They bind to the 30S ribosomal unit, which is like the factory where proteins are made.
So they shut down the protein factory.
Exactly. And without those essential proteins, the bacteria can't function and they die.
It's amazing how these tiny little molecules can have such a huge impact.
It's like a microscopic war going on inside the body.
Totally.
Yeah.
And it just shows how important it is to choose the right antibiotic for the right bacteria.
Couldn't agree more. But of course, we also have to consider the potential downsides.
Side effects, those pesky side effects.
Right, because every powerful weapon can have some collateral damage.
So what are some of the common side effects we should be on the lookout for with each of these antibiotic classes?
Let's start with the fluoroquinolones.
Those were our top contenders for Sarah.
Yeah, gastrointestinal upset is pretty common.
Like nausea, vomiting, diarrhea.
Yeah, that kind of stuff, and some abdominal discomfort.
Not fun, but usually manageable.
Usually, yeah, it's mild and goes away on its own.
But there are some more serious side effects, right?
There are, although they're rare.
Like what?
Fluoroquinolones have been linked to tendinitis and even tendon rupture.
Yikes.
Especially in older patients, people with kidney problems, and anyone taking corticosteroids.
So those are red flags.
Definitely something to watch out for.
What about the extended spectrum cephalosporins? What do we need to be aware of there?
They're generally pretty well tolerated.
That's good.
But like most antibiotics, they can cause some GI upset.
Yeah.
And we have to be careful about allergic reactions, which can be anything from a mild rash to...
Anaphylaxis.
Yeah, that's the most serious one, life-threatening.
So always be prepared for that.
Always. And then there are the aminoglycosides, which, as we mentioned, can be a bit tough on the kidneys.
Nephrotoxic.
That's the word. So we have to monitor kidney function very carefully if we're using one of those.
It's all about finding that balance, treating the infection effectively but without causing more harm.
That's the art of medicine.
It really is, and patient education is key, right?
Absolutely. We need to make sure patients understand their meds, what to watch out for, and when to call their doctor.
Speaking of patients, let's get back to our case study, Sarah.
Our high school teacher with pyelonephritis and diabetes,
We left off with her switching to oral antibiotics based on those culture results.
which showed E. coli, resistant to ampicillin and TMP-SMX.
But sensitive to ceftriaxone, levofloxacin, and ciprofloxacin.
Right, so switching to an oral fluoroquinolone seems like the best move.
So let's say Sarah is stable enough to make that switch from IV to oral antibiotics. What do we need to consider?
It's all about making that transition smoothly and safely.
And her clinical status is the most important thing, right?
Absolutely. Are her vital signs stable? Is the fever gone? Can she tolerate drinking fluids?
If she can't keep pills down, there's no point in switching.
Right. And we also need to think about the specific antibiotic we're choosing. Some are absorbed better than others.
And of course, double check that those bacteria are still susceptible.
It's a bit of a juggling act, but an important one.
So let's say Sarah's doing well on the oral antibiotics and she's ready to go home. What are the key things we need to talk to her about?
Patient education is crucial here. We want her to be involved in her recovery.
So she knows what to expect and what to do.
First and foremost, we need to make sure she understands how to take those antibiotics correctly.
Right dose, right time, for the full duration, no matter what.
No stopping early, even if she feels better.
Because that just increases the risk of the infection coming back even stronger.
And becoming resistant to treatment.
We don't want that.
And of course, we talk about potential side effects, what to watch out for, and when to call her doctor.
Anything else?
We also want to emphasize those non-drug measures that can help her heal.
Like drinking plenty of fluids.
Yes. Keep flushing out those bacteria.
And what about pain?
We might recommend urinary analgesics like phenazopyridine to help with any discomfort.
That makes sense.
And we'll encourage her to follow up with her primary care doctor or a urologist to make sure everything is healing properly and to address any underlying issues that might have contributed to the infection in the first place.
So it's a holistic approach, not just treating the immediate problem, but thinking long term.
Exactly. Now, there's one more thing I want to touch on before we move on.
What's that?
Prophylaxis.
Preventing future UTIs, is that always necessary after pyelonephritis?
Not always. It depends on the individual patient and their risk factors.
Like what kind of risk factors?
Well, a history of recurrent UTIs is a big one, especially if they've had a lot of them in a short period of time.
Makes sense.
Anatomical abnormalities of the urinary tract, certain medical conditions like diabetes, and using catheters can also increase the risk.
So if Sarah falls into one of those categories, we'd want to at least talk to her about prophylaxis.
Definitely. But it's important to remember that it's not a foolproof solution.
It's not a magic bullet.
Right. It can help reduce the risk, but it's not a guarantee.
So what are our options? What tools do we have for preventing UTIs?
There are a few approaches. One option is continuous low-dose antibiotics, where the patient takes a small dose every day to prevent bacteria from taking hold.
So it's like a constant shield.
You could think of it that way.
What else?
Another option is postcoital prophylaxis, where the patient takes antibiotics after sex.
To prevent UTIs that might be triggered by that.
Exactly.
Are there any non-antibiotic options?
There are some studies that suggest cranberry products or certain probiotics might be helpful.
But the evidence isn't as strong.
It's a bit mixed. More research is needed.
So we have a few different strategies to consider, and it really depends on the individual patient.
It's all about finding the best approach for each person.
We've covered so much ground today,
From mechanisms of action to side effects to prophylaxis.
and we revisited Sarah's case, talked about switching her to oral antibiotics, and getting her ready to go home.
It's been a true deep dive.
And I hope our listeners are feeling more confident and prepared to tackle these cases in real life.
Knowledge is power. The more we know, the better we can care for our patients.
But wait, there's more. Stay tuned for the final part of our deep dive, where we'll be tackling some challenging case studies and diving into the latest research on pyelonephritis.
And we'll be answering your questions, so send them our way through our website or social media.
Until then, keep those brains buzzing, and we'll see you soon. Welcome back, everyone, for the final part of our pyelonephritis deep dive.
We're in the home stretch now.
We've covered so much ground already.
From recognizing those early warning signs to understanding how those antibiotics actually work.
And of course, how to personalize those treatment plans based on all those factors.
Right, it's not just a one-size-fits-all approach.
But now it's time to put all that knowledge to the test. Right.
Time to apply what we've learned.
Let's revisit our case, Sarah. Our high school teacher with type 1 diabetes and that complicated pyelonephritis.
You remember those culture results, right?
Both urine and blood cultures positive for E. coli.
Resistant to ampicillin and TMP-SMX.
No surprise there.
But sensitive to ceftriaxone, levofloxacin, and ciprofloxacin.
So now that we have that information, what would you recommend? Should we adjust her treatment plan?
That's where those culture and sensitivity results are so crucial. They let us really personalize the treatment and pick the most effective antibiotic.
Okay, so what's the expert recommendation? Lay it on us.
Well, based on this, switching Sarah to an oral fluoroquinolone like levofloxacin or ciprofloxacin seems like the way to go.
They both sound like good options.
They have excellent activity against the specific E. coli strain. They're well absorbed when taken orally, and the dosing schedules are pretty convenient.
Okay, so what about dosage and how long should she take them?
For levofloxacin, we could do 500 milligrams once a day for 10 to 14 days.
Okay.
Or we could opt for a higher dose, 750 milligrams once a day, but for a shorter duration, like 5 days.
So shorter treatment, but higher dose.
Exactly.
What about ciprofloxacin?
That's typically dosed at 500 milligrams twice a day for 10 to 14 days.
Okay, so we have a few choices here. How do we decide which one is best for Sarah?
This is where clinical judgment comes in.
It's not just about the numbers.
Right. We have to consider her individual situation, her preferences, potential side effects, and even cost can play a role.
So we're really tailoring the treatment plan to her specific needs.
Exactly. But there's another layer here. Things can get a bit tricky when it comes to complicated pyelonephritis, especially in someone with diabetes.
So those guidelines aren't always crystal clear.
Not always.
The infamous gray areas of medicine.
Precisely. The evidence supports those shorter antibiotic courses for uncomplicated cases. But in Sarah's situation, a clinician might lean towards a longer duration, maybe the full 10 to 14 days, even with that higher dose of levofloxacin.
So it's a judgment call.
It is, taking everything into account.
Wow, we've really journeyed deep into the world of pyelonephritis.
We've covered a lot of ground.
From those early signs and symptoms, to choosing the right antibiotic, to understanding those side effects and tailoring those treatment plans.
And we even talked about preventing those future infections with prophylaxis.
It's been quite the deep dive, but I hope our listeners feel more confident and prepared to tackle these cases in real life.
Absolutely. Knowledge is power. The more we know, the better equipped we are to provide the best possible care.
And remember, this is just the beginning. Keep learning. Keep asking questions. Stay curious.
The world of medicine is constantly evolving. There's always something new to discover.
And that brings us to the end of our pyelonephritis deep dive. We hope you enjoyed the journey.
We had a great time.
Don't forget to like, subscribe, and share this episode with your fellow Health K warriors.
And keep those brains buzzing.
We'll see you next time for another exciting deep dive.